Someshwar Garu, now we can start.
Yeah, thank you, Savan. Ma'am, with your permission, shall we start?
Yes, please start.
Thank you, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the delegates to please do comment your queries in the comment box so that at the end of the webinar, we'll have a short Q&A session. So now let me welcome our today's eminent speaker, Dr. Mohammed Shama Sultana ma'am, who is a young, enthusiastic and cheerful ops and gynecologist as well as infertility consultant. She is the chairman and co-founder of Hope Win Hospital and also working as a gynec consultant at the Hope Hospital. And she's also did her PG diploma in assisted reproductive techniques from Kehl University, Germany, and training in basic ultrasound and endoscopy from Foxy. And also she have done her diploma in aesthetic gynecology. And also she has a colposcopy expert training from Delhi Gynec Forum. She has been a speaker in femicide in Community Connect program on preventable women's health care held in May 2021. And also she is an public awareness in charge in Sexual Medicine Committee, Foxy, and editor-in-chief of Dr. Parag Patil's Awareness E-Digest. And she is also served as a faculty and moderator for Open Forum Awareness on Adolescent Sexual Health organized by POGS in June 2021. And she is the founder of UNRS Healthcare organization in Guntur for adolescent and young women health awareness mission. And not only this, she has done so many webinars and many programs in educating and awareness regarding women's health. So with this, we welcome you, ma'am, for today's webinar. And as we know that the precise cause of PCOS is unknown, but several possible reasons could result from a combination of genetic, lifestyle, and health factor. And recent studies have shown that there are more light on precise cause and management of individual in PCOS. So now, without wasting much time, let me turn over the time to Dr. Shama Sultana ma'am to talk on recent advances in PCOS. Over to ma'am.
Yeah, thank you so much. And thank you for Shield Healthcare to give me this opportunity to talk on the most burning topic, that is PCOS. Actually, I was much more interested in attending this webinar and giving a speech on this topic because nowadays youngsters, that is adolescent as well as young people who are in the reproductive age are really messing up with this PCOS. They are not understanding why they are getting it, and if they get it, how to resolve it, they don't know, and they don't understand whom to approach. If approached also, the person who is treating them is either way, they are not able to connect with them and tell them the proper treatment it should be, because it is a multifaceted. So if it is treating in one way, it will be worsening in one way. So it should be multifaceted and multidirectional and multifactorial treatment. So let us understand what all things we are coming to know and recent advances, what all there. Is my PPT shared?
Yes, ma'am. We are able to see, ma'am.
Okay. Okay, let's start. So today's topic is recent advances in PCOS. So as we see, it is not merely a reproductive disorder, but an endocrinological disorder that is affecting in the women in the reproductive years. And as we see, the definition itself says it is a hyperandrogenism, that is androgen excess, and it is leading to infertility. That PCOS causes distressing to young women. Its metabolic sequelae or eventually plague the individual in terms of morbidity as well as mortality. So it is crucial to diagnose PCOS early in its course. It is imperative not only to recognize it, but also to delay or arrest its metabolic sequelae. Then additionally, screening for the expected complications may allow for proper and timely management of these conditions. So in this, although PCOS is associated with hyperandrogenism and infertility in early life, it is harbinger of a lifelong condition that can lead to serious sequelae such as diabetes mellitus, hyperlipidemia, endometrial hyperplasia or carcinoma, and central obesity and sleep apnea, and etc. So why a physician should know about PCOS, or from which disorders or complications a patient could be safeguarded? That is, the diagnosis of PCOS implies that a woman is at increased risk of the following, like infertility, dysfunctional uterine bleeding, endometrial carcinoma, obesity, obstructive sleep apnea, type 2 diabetes mellitus, dyslipidemia, hypertension, possibly cardiovascular diseases. Then her siblings, like her sisters, daughters, and other close female relatives, are also at higher risk, and she may require lifelong therapy and find that her access to healthcare coverage. So, how much it is prevalent in India or other places, or totally in women, is it is one of the most common endocrinal disorders affecting women of reproductive age, and it is seen in 8 to 11% of reproductive age group women. So most common cause of anovulatory infertility in women is PCOS, and anovulatory infertility, that is 70 to 80%, it is due to PCOS. And Indians, again, we are the top. Indians have amongst the highest prevalence rates in the world, that is 41% in reproductive age. So we are at a higher risk. So we need to be known and be aware of this condition. So PCOS, an epidemic in India, as over I see, that is as more as COVID cases, it is more prevalent now as a PCOS case. So if suppose among 5 people are coming to me, more than one now I'm seeing as in case of PCOS, I'm getting cases that much frequent, and they are very much more than as the epidemics we see here, epidemiology we see here, it is more than that. So as we see of, it is 41% prevalent in India, and also 117 million patients are rising, and 1 in every 5 women, I see more than 1 woman in 5 are coming. Like 10 patients are coming among those of irregular periods. It is the cause of PCOD in among 8 patients. So these are the complications we face in PCOD, that is infertility, obstetric causes, and also obstetric complications we get, and cardiovascular complications, metabolic complications, and oncological complications are there, and psychological complications as well. As this is a history, little I want to tell you that still Leventhal has designated PCOS as syndrome, and addition to it, it was ultrasound criteria added in 18 and 90s, and Rotterdam Conference as held in 2003, and international evidence-based guideline for assessment and management of PCOD was done in 2018. So ultimately, definition of PCOS is not yet universally accepted and perfectly noted as this is the definition of PCOS. Still, if we need to say, according to 1990 US NIH consensus conference, there are 2 minimal criteria should be there, like irregular periods due to oligomenorrhea or anovulation, and there will be a clinical or biochemical hyperandrogenism, that is they could be presenting with hirsutism, acne, and male pattern baldness, elevated serum androgen levels, and above not attributable to other causes. So there would be no laboratory evidences required for diagnosis, but also no radiological evidence required for diagnosis. It is in North America, but here we see mostly significantly in most of the patient, there would be significantly seen in ultrasound, or if it is not seen also, it could be we can take it as a other irregular periods. Hirsutism can also be defined as a this PCOS. So ovarian appearance not pathognomic, and insulin resistance not included in diagnostic criteria, and it excludes women with other known causes of hyperandrogenism, diagnosis of exclusion. So clinical heterogeneity also can be seen. So what is polycystic ovary? We say polycystic ovary, you have polycystic ovarian syndrome. Then what is polycystic ovary? It is ovary containing 12 or more follicles that is measuring 2 to 9 mm in diameter. So if the follicle is more than 2 to 9 mm in follicle and there are 12 or more follicles in an ovary, that is called polycystic ovary. And the ovary which is having a volume of greater than 10 ml on ultrasonography and a single ovary meeting either or both can satisfy this criteria. So ultrasound should not be used for the diagnosis of PCOS in those with a gynecological age who are less than 8 years, because it will be a higher incidence of multifollicular follicles in this stage of multifollicular ovaries in this stage. So 2003 history and ASRM Rotterdam consensus on PCOS, it requires the presence of 2 out of these 3 criteria, that is oligo and anovulation, hyperandrogenism, androgen excess. It could be clinical and or biochemical, and polycystic ovaries with the inclusion of other things. So these 3 criteria, if 2 are satisfactory, it could be a mark of PCOS. So as we have seen that complications of PCOS, we have seen infertility. Primary infertility was reported in 50% of women and secondary infertility was reported in 25% of women. And obstetric causes FCC, when they are getting pregnancy beyond the PCOS condition, they may be at risk of 3 times higher risk of preeclampsia, 3 times higher risk of GDM, 2-fold increase in preterm deliveries, 2-fold increase in risk of IUGR. They could be at higher risk of cardiovascular diseases, like 2-fold increase in risk of MI, 2-fold increased risk of hypertension, metabolic disorders, like 5 to 10-fold increase in risk of developing type 2 diabetes mellitus, and gynecological disorders, that is increased risk of endometrial cancer, also it is risk in PCOS. So psychological disorders, of course, 4-fold greater odds of depressive symptoms, high prevalence of anxiety disorders, reduced quality of life. The psychological disorders is really hampering their life. They can't concentrate on their work, studies, as why their periods are not regular, why they are gaining weight, or why they are not properly getting menstrual bleed. They may be having oligo, like scanty flow, and they may be not getting enough of bleed whenever bleeding comes. And for suppose in few of PCOS conditions, there will be a heavy flow after 2 to 3 months of amenorrhea. So these conditions really are making them depressed and also making the causes of anxiety a lot of more greater side. So diagnosis of PCOS, these are the 1990, 2003, and 2006 guidelines, what we are following. So mostly ASRM, I want to tell you, that is 2 out of 3, which I have already told you: oligo or chronic anovulation, and clinical or biochemical hyperandrogenism, and polycystic ovarian morphology. So what could be the pathogenesis? See, it could be genetics or it could be due to lifestyle factors. So epigenetics leading to hormonal changes, which is exacerbated by obesity, which is leading to also low grade inflammations and hyperandrogenism and insulin resistance, which is leading to few characteristics of oligoanovulation, menstrual irregularity, and subfertility. And due to hyperandrogenism, there is a clinical conditions of hirsutism and acne. And due to insulin resistance, there will be a metabolic syndrome. There will be increased risk of cardiovascular risk factors, and also insulin glucose intolerance, that is leading to type 2 diabetes mellitus. Psychological issues like body image, self-esteem, depression, anxiety also is one of the conditions resulting due to these all factors. So what will be the spectrum which are forming a symptoms in the age group from the childhood to the postmenopausal years? So predisposing factors, like in childhood, they will, if they are PCOS condition, they are having PCOS condition, it could be due to genetic factors or in vitro programming. Due to that, they could have this PCOS condition, or due to increased AMH levels, they could have they could be facing in childhood. If non-PCOS, no conditions would be seen, they will be normal. And in puberty, they will be in PCOS, they will be landing in PCOS due to premature adrenarche, hyperandrogenism, increased GnRH pulse frequency, increased AMH levels or ovarian volume, and also hyperinsulinemia. And in conditions of non-PCOS, in puberty, there could be acne, increased ovarian volume, irregular menstrual cycles, insulin resistance of puberty. It could be a physiological thing. In case of reproductive years, irregular cycles, hyperandrogenism, subfertility or infertility, increased AMH and antral follicle count is decreased, and ovarian volume is increased, glucose intolerance, insulin resistance. These all could be seen in PCOS. Whereas in non-PCOS people, there could be decreasing androgen levels with age and decreasing AMH and ovarian reserve, and also and antral follicle count with age will be decreased. Then in postmenopausal years, if there is a PCOS condition, increased prevalence of hypertension, increased triglycerides may lead to this sort of morphology. Then in non-PCOS conditions, increased cardiometabolic risk factors with menopause like glucose intolerance, adiposity, and hypertension. So these are the phenotypes of PCOS across the lifespan of comparison with controls. So these are the 4 phenotypes A, B, and C, D. These hyperandrogenism, ovarian dysfunction, polycystic ovarian morphology could be different. In phenotype A, all 3 could be there. Phenotype B, 2 out of 3. In phenotype B, we can exclude if they means if the criteria, which is polycystic ovarian morphology, is not seen in ultrasound, then they are designated as phenotype B. And if there is hypoandrogenism and hirsutism and also polycystic ovarian morphology and without ovarian dysfunction, there could be phenotype C. So in which irregular periods and in morphology, like in ultrasound, if they have polycystic ovarian syndrome, but they are not seen with hirsutism or male pattern baldness or acne, they could be phenotype D. So like these 4 phenotypes could be seen, and all we can consider as PCOS and treat. So PCOS in adolescents, the more common condition which I'm seeing these days, more of the means adolescent PCOD are coming from the age group of 13 to 17, 19. They are coming in those ages with a severe condition of PCOD. One of the 13-year-old girl have come to me, and she was with a very huge ovarian volume. Like she was 14 years, and she came with a complaint of irregular periods sometimes, and when the bleeding comes, it will be prolonged for 15 to 20 days, and it was so messy. Not only her, the 4-5 girls of that age group who were very severe. Others, compared to others, these were the girls whom I was very much worried. In such an age group, they were having so much complication with those polycystic ovarian syndrome. So the scenario was like they're having irregular periods, they were having hirsutism, and also there were conditions where they had overweight. There was a lot of overweight. Like at the age of 14, they were 60 kgs, one was 65 kgs. So it was a morbid obesity, overweight, and they were having a family history of PCOS as well. So in those and the morphology of PCOS was also seen, and the ovarian size was, one ovary was 4.2 centimeter, one ovary was 4.9 centimeters. So after 3 to 4 months of treatment, when I repeated the scan, it was like 2.5 and 2.7 centimeters of ovaries. So likewise, the amount of treatment we do in a multifaceted way, surely it will help. The people should understand it's a treatable disease if all the faceted approach if we do. So PCOS is often diagnosed in adolescence. It is absolutely true. And utero exposure to fetal testosterone, hypoglycemia, and hyperinsulinemia determine PCOS phenotype. So in risk factors, as I told you, family history of PCOS, overweight or low birth weight, exposure to androgens during gestation, and precocious puberty and obesity, insulin resistance, and the diagnosis of PCOS during adolescence requires stricter criteria. So requires unequivocal hyperandrogenism and ovulatory dysfunction for greater than 2 years. So here also the same, like genetics and lifestyle factors which are causing the hormonal changes, and of course obesity is exacerbating hormonal changes, and increased androgens and increased insulin leading to ovarian follicles, means a dysfunction and anovulation, and there is a increased levels of estrogen and increased levels of androgens causing hirsutism and acne, and ovarian dysfunction is causing the menstrual disturbances and subfertility, and diabetes metabolic syndrome is caused by increased levels of insulin, and also there would be cardiovascular risk also. So again, psychological psychosocial issue will come, like body image, self-esteem, and depression and anxiety are seen in these girls. So here we see the epidemiological link, like PCOD increases the risk of GDM as well by more than 200%. 200%. Then PCOD increases the risk of type 2 diabetes mellitus by 1600%. Then insulin resistance in present is present in PCOD with a risk of 65 to 80%. Okay. Then 60% of GDM patients develop type 2 diabetes mellitus as well. So what is pathophysiology of PCOS? So considerable debate should happen on the what exactly constitutes PCOS and key biochemical features present in the vast majority of women with PCOS, insulin resistance, and chronic low-grade inflammation in PCOS. So pathophysiology, as we see from adrenaline, DHEAS is coming, and when they are increased, and it is leading to estrogen. When the aromatase hormone is there, that will change from the skin. This the estrogen is converted into the estrone. Okay, estrone. It is converted to estrone, which is making the endometrial hyperplasia at one place, and due to insulin resistance there is changes in the liver enzymes as well, and when there is a altered sex steroid levels in the hypothalamus, and it is leading to abnormal GnRH secretion in pituitary, LH is increasing and FSH is decreasing. Okay, then when these are abnormalities are there in ovary, due to LH increase and FSH decrease, there is the ovarian dysfunction. So when there is no follicle stimulating hormone, there would not be any ovulation, and thereby there will be a periodic dysfunction. So development of insulin resistance, as we see, there is a controls LH control levels and controls androgen levels, increased insulin resistance, which is coexisting during PCOD. Inositol deficiency drives PCOD, and insulin signaling is damaged in PCOD, and later is leads to hormonal metabolic defects. The mainly what happens is this: when it insulin resistance happens, this glucose is not converted into inositol. Inositol comes in the body when glucose is converted to inositol by insulin. So when inositol deficiency is there, which is enhancing the ovarian health, there could be a ovarian dysfunction. So insulin signaling is damaged in PCOD, which is leading to inositol deficiency. So evolution of PCOD as a summary: environmental factors, inositol deficiency, deranged insulin signaling, which is leading to pituitary dysfunction and enhanced ovarian androgen production, then development of insulin resistance. In this, genetic factors also are responsible, which will lead to these all cycle. So these are all the androgenic and gynecological and metabolic symptoms. This here you see the acne, weight gain, and also hair loss, hirsutism, and here you see the acanthus nigricans. So clinical hyperinsulinemia, insulin levels may be increased in a majority of patients with PCOS. A ratio of fasting glucose to fasting insulin is simple and effective, and a ratio of greater than 7 suggestive of hyperinsulinemic state. A fasting serum insulin level greater than 15 and a serum insulin level post 75 gram glucose of insulin will be higher than that. So the people who are trying to get pregnant with PCOS condition, they may get few complications like They may be landing up in the other artificial reproductive techniques. So they may be leading to have multiple pregnancies. Multiple pregnancies are most important cause of increased means morbidity or mortality of the fetus, and perinatal morbidity observed following fertility treatments. There would be miscarriages. It is still debated whether women with PCOS have an increased risk of miscarriage. And pregnancy-induced hypertension and preeclampsia are higher at risk, and three to four-fold increased risk are present in PCOS for all other complications. So first-line treatment would be, first is we tell to improve the lifestyle. So lifestyle modifications would be the first step where we ask them to correct their lifestyle modifications. It could be a simple exercise or simple lifestyle modification, which junk food they eat they can stop, or the healthy lifestyle, healthy food they can take. In obese patient, of course, we will ask for weight loss, change in the diet, and physical activity is recommended. Weight loss decreases serum insulin and androgen levels, reduces the risk of glucose tolerance, intolerance, and type 2 diabetes mellitus. So pharmacologically, interventions we will give as in presence of insulin resistance and glucose intolerance or dyslipidemia that persist after lifestyle modifications. So treatment strategy would be, first we will correct the hormonal imbalance and metabolic imbalance. Hormonal imbalance when there is a hyperandrogenism and LH-FSH imbalance, which are like symptomatically we will try to treat, that is oligoamenorrhea. Oligo or amenorrhea we will treat, and anovulation we have to treat, then acne, hirsutism, virilism, and acanthosis nigricans. Impaired glucose tolerance and obesity have to be taken care of. Then what we are currently doing is we are giving insulin sensitizers like metformin and pioglitazone, then anti-androgens like cypoteron we are giving, and then oral contraceptive pills like we are giving for hormonal balance. Then ovulation inducers like clomiphene citrate, letrozole, anastrozole we are using for ovulation induction. Cosmetically, we can go for laser hair removal or bariatric surgery and acne therapy. Then others like statins we are giving. So managing menstrual disturbances, like if they don't wish to conceive, or any medical therapy for interruption of estrogen. Then non-fluctuating estradiol in the absence of progesterone cause irregular uterine bleeding. Then oral contraceptive pills elevate risks for cardiovascular diseases, dyslipidemia, and thromboembolic events. Increased risk of type 2 diabetes mellitus with the oral contraceptive pills, which is dose dependent. So low dose oral contraceptive pills are recommended in this case. So fertility treatment options, like there are many, like we improve the chances of conceiving in PCOS. Like in 30%, no problems in getting pregnant, but in 70% of them can experience problems in getting pregnant. As I have already told you, there could be miscarriages, there could be multiple pregnancy, like that. Many causes, many complications would be there. So women with PCOS commonly have problems becoming pregnant. The most common reason is not producing a fully developed egg during monthly cycle, that is anovulation. As I told you, there will be decreased levels of FSH, and of course there could be hampered ovulation. So treatment in infertility in PCOS as a algorithm, first line treatment non-pharmacologically, management of infertility is lifestyle interventions. Then first line pharmacological management for infertility we do with letrozole, clomiphene citrate plus metformin, and gonadotropins. Like this, we will do ovulation induction. Then second line pharmacological or surgical management we can do is gonadotropins we can use in step up or step down procedure, and laparoscopic ovarian surgery we can do. So third line management would be other appropriate interventions, including IVF. So letrozole, clomiphene, and metformin. So letrozole should be considered first line that is pharmacological treatment for ovulation induction in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth rates. Where letrozole is not available or use is not permitted or cost is prohibitive, health professionals should use other ovulation induction agents. Health professionals and women should be aware that the risk of multiple pregnancies appears to be less with letrozole than compared to clomiphene. So clomiphene and metformin for anovulatory infertility in obese, that is BMI more than 30. Clomiphene is preferred. In obese, that is BMI more than 30, combination of clomiphene and metformin should be preferred rather than metformin alone. So gonadotropins are the second line of treatment ovulation in the ovulation induction in the anovulatory infertility. To use in clomiphene resistant patients, we can do this, and gonadotropins plus metformin in clomiphene resistant patients is much more helpful. So laparoscopic ovarian surgery we do, that is laparoscopic ovarian surgery could be a second line of therapy for women with PCOS who are clomiphene resistant with anovulatory infertility and no other infertility factors. So laparoscopic ovarian surgery could potentially be offered as a first line treatment if laparoscopy is indicated for another reason in women with PCOS with anovulatory infertility and no other infertility factors. So risk should be explained well to all women with PCOS considering laparoscopic ovarian surgery, that the following treatment, it is comparative cost and expertise required for use in ovulation induction, intra-operative and post-operative risks and are higher in the women who are overweight and obese, and there may be a small associative risk of low ovarian reserve or loss of ovarian function after this procedure. Periadenic cell adhesion formation may be an associated risk after the procedure. So bariatric surgery for weight management could also be an option to for the weight loss. So bariatric surgery should be considered an experimental therapy in women with PCOS for the purpose of having a healthy baby with risk to benefit ratios currently too uncertain to advocate this as a fertility therapy. If bariatric surgery is to be prescribed, the following should be considered, like it should be a comparative cost, the need of the structured weight management program involving diet as well and physical activity and interventions to improve psychological factor, muscular and cardiovascular health to continue post-operatively. Then perinatal risks such as small for gestational age, premature delivery, or possibly increased infant mortality rate also should be explained so as to they should know prior to the go to this bariatric surgeries. So potential benefits such as reduced incidence of large for gestational age fetus and gestational diabetes shall also be make them know. Recommendations for pregnancy avoidance during periods of rapid weight loss and for at least 12 months after bariatric surgery with appropriate contraception. So IVF recommendations, there could be ovarian stimulation should be done, and monitoring shall be there with follicular study. Follicular growth is monitored, then egg retrieval will be there, and follicular aspiration done, and eggs are retrieved, and embryo transfer will be there. So improving chances, that is contraception is a need if pregnancy is not desired. So we are improving chances of their well-being and all, and discuss family planning also, and pregnancy and health with your doctor, as make a plan of action so that you will be in the best health possible when trying to become pregnant. So aim for the healthy weight, that is to reduce weight and to improve your chances of getting pregnant. And if you are in an unhealthy weight range, that is 5 to 10% weight loss of total body weight will improve your chances of becoming pregnant. So another thing is consider planning your family. If you wish to have children, then it should be better if it is earlier than 35 years. So one of the most important drug we are using now is Inositol, that is Inositol in PCOS we are using. And this is helping in the insulin signaling. So insulin receptor resides in the cell membrane, and when its B subunit is phosphorylated by insulin receptor substrates are activated. So P13K and docks to the IRSS, so which then leads to phosphorylation of phosphatidyl inositol, eventually in inulin action. So myoinositol increases insulin sensitivity by making more phosphatidyl inositol available. So myoinositol and dichloroanisitol deficiency in PCOS is seen, and both of them are very low in PCOS patients compared to normal subjects. So myoinositol, what it is doing, if it is like myoinositol and dichloroanisitol are 40:1 in PCOD, and if they are improved, they will helpful for normalizing the insulin signaling, and they will helpful for glucose metabolism, which will lead to insulin resistance decrease in the insulin resistance. And when these are given as supplements, there could be decrease in the inflammation of ovarian theca cells, and also androgen levels shall come down to normal. Then it should also be helpful in LH levels will be lowered, and it will come to the normal levels, and it will revert back coming the menses. Periodic irregular periods shall be normalized, and also it should help in normalizing the insulin levels, or insulin resistance shall be controlled, and in insulin levels become normal, and it shall be helping for weight loss. So ultimately fertility shall be restored. So inositol favors live birth rate in PCOS. So it is very much helpful, as a Cochrane library has given a study in which it is showing after the use of inositols, there is increased, and it is favoring the live birth rate in PCOS conditions. So conclusion I give is PCOS is a multifaceted condition. In one way, if we don't go for lifestyle modifications and only concentrate upon the correction of irregular periods or giving the hormone therapy, it doesn't mean it will decrease it. When you are stopping the hormone therapy, again they will revert back to irregular periods and everything. If everything is not maintained well, and if they are not treating the main cause why it is happening, as I have told you, the insulin resistance or the increased androgen levels, if these are not cared, then of course the irregular periods will revert back when the medication is stopped. So it is a multifaceted condition. Multidisciplinary approach for subfertility and ovulation should taken care, and a holistic care to increase the success rates of fertility treatments should be taken care, and lifestyle modifications like diet and exercise and behavioral therapy or principal treatment, and low dose gonadotropins can be used as a first line agent when affordability and accessibility are not major issues. So IVF and ICSI indicated when previous interventions failed in tubal occlusion or male factor. So thank you so much. So PCOS, this we can give as a prepare, communicate, overcome, and support. Prepare and assist women with the necessary information and resources needed to get tested. Then communicate information to the public and to women diagnosed with PCOS. Overcome, assist women diagnosed with PCOS to overcome their symptoms and lessen related health risks. And support, provide a support network to freely and openly discuss all aspects of PCOS. For this, I'm planning for a PCOS awareness among the people here. So through our Juvenaris Healthcare organization, we have conducted many PCOS awareness programs, and further also we are planning for PCOS awareness programs, a lot workshops, and how we can make people much more understand about this PCOS. Like we see, the main motto of Juvenaris Healthcare is not that the patient come with a disease, but our motto is that the patient should not reach to the disease. The disease should not reach the person whom it should make a unhealthy PCOS condition. If they are contacted with this PCOS condition, it not go to the severe level. So it is the main motto of YNHC, and we are planning for much more awareness programs, and we are also planning for an app in which you can be knowing more about PCOS. You can communicate with us whenever you are needed. So it will be much more helpful. So thank you so much, Shield Healthcare, to give me this opportunity to talk about this very sensitive topic. And much more I want to know, and I want to tell about PCOS much more in next classes, next webinars as well. Thank you so much.
Thank you, ma'am. It was a nice presentation. We are very honored and learning to hear you, ma'am. Ma'am, if you allow me, then we'll take the questions.
Yeah, of course.
Ma'am, we have a first question. That is, if one ovary is involved,
Yeah.
even then label PCOS.
Yes. If one ovary is satisfying all the causes, like all the criteria, that it is having more than 12 follicles in a ovary, and it is more than volume is more than 10 cc, so it is labeled as a polycystic ovary. Then along with this, they will be having other irregular periods or hirsutism and other symptoms, which is forming the criteria. Okay, as we have seen in the phenotype, in the some phenotype like C and D, like where we are not following few of the guidelines, like in some hirsutism is not there, in some ultrasound criteria is not there. But if both the sides ovaries are with PCOS, we will call bilateral PCOS or unilateral PCOS.
Thank you, ma'am.
Thank you.
Ma'am, we have one more question, that is psychological role in PCOS.
Yes. So psychological it's a major role actually, because the moment I have seen much of the patients, they are all complaining of insomnia. Nowadays, from the adolescent age to young age group, everybody is facing insomnia in one or the other form. They are watching cell phones and they are not able to sleep properly. And in whole of my talk, I have missed one thing, that is melatonin hormone, which shall be playing much more important role to regularize testosterone and estrogen and progesterone in one way. So in when the people the when the woman sleeps, and the hormone which is regulating, it's not producing, it may further cause her a lot of disturbance in her life, anxiety, depression, on the other day. See, insomnia, then loss of production of melatonin, which is not regularizing the hormones. In terms, they will be having hormonal disturbance, and also they will be having anxiety, depression on the other day, and it is will be increasing. And due to the absence of their regular cycles, they will be having a lot of depression. As I see, many of the girls are so much worrying about their periods. Wherever we go through YNHC workshops, their girls are very much worried about their heavy periods sometimes, and few girls are worried about their absence of periods. So this is really affecting psychologically on the adolescents and young. And moreover, when there is a infertility or subfertility, people are coming with a lot of depression. Of course, there will be a peer pressure, as well as from the elders there will be a peer pressure, and from the society there is a very much pressure on them due to subfertility or infertility. So it is playing a major role. Due to this disturbances and anxiety in the body, there will be a psychological disturbance, and there will be hampered metabolism, and also there will be hampered ovarian function. So it is leading to, of course, inflammations, and which are causing the PCOS. So in this way, psychological effect are really affecting bad in PCOS patients.
Thank you, ma'am. We have one more question, that is a 18-year-old thin adolescent girl with irregular periods and mild acne and hirsutism with a darkening and thickening of skin on chin.
Yes.
Without ultrasound evidence of PCOS with dysmenorrhea, and how
Yes.
to treat this adolescent PCOS.
Yeah, I have many patients in this age group with similar conditions. First of all, when the patient come and give me irregular period history, first of all, I want to see their androgen levels. One patient with these conditions came to me, and she was having testosterone levels 89, which is slightly very much raised, and also insulin at a higher side, and her diabetes means her HbA1c was 8. So according to these all conditions, without any ultrasound report was normal. Her little bigger, means 3.4 and 3.7 centimeters ovaries were there, and without much of the polycystic appearance. So in this condition, first of all, we have asked her to still means change her lifestyle modifications. Just diet, I have explained her a lot, because she would not eat any healthy food. She is always upon junk food like chips, kurkure, and all that junk food which she can eat, and cool drinks. And I asked her to stop all that junk food, and she can go for healthy habits like walking for 30 minutes. Still, she is lean and thin, but still, to increase the metabolism, she can go for 30 minutes walk in the sunlight. At least for half an hour she can spare time, because ovary needs few of the vitamins and proteins, vitamins like vitamin C, vitamin E, vitamin A, and vitamin D, which are very much essential, and they are not taking in proper quantity each day. So if these all are deficient in one's body, of course they will be having poor ovarian health and poor ovarian reserve. These all conditions will be resulting due to this. So ovary needs proteins as well, which are not taken by the adolescents or younger age group. So it is resulting to this condition, PCOS. So if proteins are taken, vitamin D, vitamin E, vitamin C, and vitamin A, if these all or supplements are given to them, it will heal a lot of problem. And also inositols like that we need to treat. And also for hirsutism, we have to take a cypoteron as a normal therapy for 2 to 3 months. Surely the testosterone levels will decrease, and due to these proteins and vitamins, surely the ovarian health will improve. Inositols should be given, and for this have kept metformin, insulin resistance, to decrease insulin resistance. I have kept on her metformin, and have told her to do regular exercise or walking for 30 minutes. And she can take all other supplements like fruits, dry fruits. She can go for a lot of hydration with fruit juices, but she should take a lot less of carbohydrates. She can increase in protein and fiber diet, and fat and carbohydrate diet should be decreased. Fruits, she could take apple, oranges, grapes, and guava, pomegranate. Like this, she can take these fruits in 2 episodes of day, that is 11 a.m. or 4 p.m., 5 p.m. She could take for 2 episodes, and in 1 episode she can take dry fruits like badam, 4 badam a day, and she can take akhroot. Akhroot means walnut. She can take one walnut a day. And anjeer is a means it is a sweetened fruit, but it is very healthy. In case of PCOS, she can take one. In this in the all these she can take in 1 episode. Then she can take a salad, that is a carrot, she can take one, and beetroot 2 to 3 slices, and cucumber and tomatoes she can take half a day without seeds. So this she can take. And also she can be hydrated with few fluids like buttermilk, and sabja water, 2 teaspoons in 1 glass. And she could take a few like ragi, like in milk and ragi, and buttermilk and ragi. And she can take fruit juice without sugar, and coconut water in which that coconut is not formed. It will have a high caloric index if it is formed. So only a tender coconut she can take with water. And means also she can be hydrated with all other fluids. She could take 2 egg whites per day, which shall give them proteins. And also 1 bowl of curd and 1 bowl of oats she could take. So by this diet modification and the lifestyle modification, along with the normal medication, so by all this we can treat them for sure in 2 to 3 months. Yeah, thank you.
Thank you, ma'am. Thank you very much for the elaborative answer. And I think there are no more questions from the delegates. If you allow me, then we will close this webinar, ma'am.
Yeah, please close the webinar. And I just want only to say, if they are seeing these symptoms like irregular periods, don't delay, just come upon and meet a gynecologist and see your reports, like how I have told you, like this we can go for reports. And I request all the gynecologists to once look for androgen excess, that is testosterone, in all the PCOS or irregular periods, because in every 1 in 5 or 1 in 2 is compulsory in PCOS, there is a excess androgen, for which we have to early diagnose and decrease the testosterone levels. And I have seen many of the infertility clinics, they are not going for testosterone levels, and they are only going for ovulation induction in PCOS conditions, which shall not make effective result. In some, in which there is a chance of lesser chance of complications or lesser degree of PCOS. In them, with ovulation induction we are getting result, but without decreasing the severity of PCOS, if you're going for ovulation induction, there is no chance of ovulation at least. So decreasing the PCOS condition with decreasing decreasing this testosterone levels, insulin resistance, and their modification, lifestyle modifications, if improved, compulsorily we can go for a normal cycle and we can get success. So thank you so much, so that I have shared my view. Thank you, Shield Healthcare, for giving this opportunity.
Thank you very much, ma'am. And we are very honored to have you, ma'am, and we look forward for your continuous support for the educational activity. And also we appreciate your efforts in community health for the women's. We are very glad to have you, ma'am, and many thanks from the Shield team. And I also thank all the delegates for their active participation. Thank you.
Thank you, Meshwar sir.